Good morning. My name is Sridhar Venkatapuram. I'm a senior lecturer in global health and philosophy at King's College London. My job today is to keep time, and I will be doing so to my best of my abilities. I don't have a big speech, and I don't want to sort of constrain the thought or the discussions that are going ahead. However, nevertheless, I have two things that I wanted to say. One is that I think that it would be a real shame if what we did in these 2 days is simply to listen and then to walk away. And so what I have is an assignment for you, which is that I would like to do some triangulation. So I think that what we have done so far is that we've done a lot of macro. We're doing some meso, and I think that what I understand is that this panel that we're about to do is a bit more micro. And so people talk about talking to their taxi drivers. I have a feeling that the people that we are going to hear from have actually quite a lot of experience in how to interview people who may or may not be taxi drivers and do it quite well, and have something to say about that. And so I think that there is a lot to be learned from sort of being able to look at all three levels and do some triangulation, and also, more importantly, to think about, and then so what? So what does this mean for us? The second point that I would like to talk about is the comment from our friend from CEDA. I don't know if you did say CEDA or something like that. I think that I didn't hear what somebody else heard, which is that I don't think the comment was about solidarity. What I heard was that there is a reaction against too much emphasis on minority communities, right? And this is something that I do think that we need to pay attention to, which is that in every country that I know anything about, there is a movement by what we would call the majority, or the middle classes, or whatever you might say, which is that they have been ignored by the government, which has been focusing too much. And this is a problem for us in the UHC, because we do want to make sure that the worst off in any given society is included in the coverage of our access to health or health care. But there is a political ethos now that we've been giving too much special attention to minorities. And so solidarity is not necessarily the word that's going to solve that problem. There is a bigger question here about how do you make an argument, or how do you convince people that everyone should have access to it, and what happens to the people who feel as though they've been ignored so far. So I'd like to just sort of keep those in the back of your mind, and I don't think that should dominate what we think about, but I just wanted to point out that I don't think that that's what necessarily what the comment was about. So I'm really excited about these next three speakers, and their biographies are on the website, so I'm not going to do any introductions or formal introductions. What I'm going to tell you is that I'm going to use an alarm, so it's not a... Great. I'm going to use one anyway. So what is it? You don't want to... Okay. So... yeah, okay, fine, then I don't have a job at all, then, okay. So, the first speaker is Katerini. Do you want to come up?
Yeah, sure.
Be careful of this.
Yeah, thank you. All right. Okay, good morning, everyone. My name is Katerini Storeng. I'm Associate Professor at SUM, the Center for Development and the Environment. I'm indeed trained in anthropology, but today I'm actually going to do more of a macro-level analysis, if only to make the case for more micro-level research. And this is work that I've done collaboratively with Antoine, our wonderful organizer here. So, as we all know here, the growth of governance beyond the nation state is a really significant historical development. It's even been called one of the most distinct political developments over the past half century. And of course, this is clear, especially so in the global health field, where, as David McCoy told us yesterday, the structures of the global political economy are mirrored in all our structures. And we've, of course, seen this shift from a system of intergovernmental collaboration overseen by the World Health Organization to an extremely complex system of governance, which we've just learned is even more complex with the financialization of health, but a system in which for the past 20 years or so, partnerships between public and private actors have come to dominate as a form of governance. And of course, this model of governance has been widely praised for innovation and decision-making and for saving lives. But there have also been many critics who have pointed out that the power imbalances within this new form of governance are eclipsed by the use of the term partnership. And many have turned to civil society as a sort of panacea that can overcome this democratic deficit. So, for example, in an editorial in The Lancet a couple of years ago, Richard Horton talked about how many in the global health field turn to civil society to provide essential voices in the discordant global health conversation dominated by risk-adverse multilaterals, corrupt governments, and neo-colonial donors. And others have talked about the way in which civil society organizations can be considered the catalyst for the transformations that are needed to achieve health in the Sustainable Development Goals. And of course, this is sort of rooted in the iconography of social movements from the 1960s and 70s, where we have democratic grassroots membership organizations calling for health for their communities. But we were interested in interrogating how well this iconography really captures the role that civil society plays within global level governance mechanisms for health. And so we asked a series of quite descriptive questions, really, looking at global public-private partnerships for health, like the Global Fund and the Gavi Alliance. How do specific partnerships actually define and conceptualize civil society? What functions do they expect their civil society partners to fulfill within their global level decision-making processes? Who actually represents civil society within the partnership's governing bodies at the global level? And what level of formal power do they have relative to other partners in these constellations? And so we did a review of publicly available documents, no interviews or ethnography at all here, but we just looked at what they actually say and how their structures are organized, of 18 major global public-private partnerships for health, focusing, as I said, at their operations at the global level. This is just a list of them. And you will see that they have in common that most of them were formed around the year 2000 or later, focusing on specific diseases or commodities or issues, often with headquarters in global centers of powers like Geneva, Vienna, Washington, D.C. Now, when we looked at all the documents on their websites and files, we found that very few of them actually define civil society at all. In fact, the Global Fund was the only public-private partnership we found that offered a definition. But when we interrogated their language, we found that of those who defined civil society, there were only 4, they're listed here. The sort of common denominator in what sort of groups or entities constitute civil society was NGOs, and affected communities or groups of patient representatives. Some included also academia and research interests within the definition of civil society, or professional organizations for health workers, or faith-based organizations, but it was really this NGO and affected communities that was the core of their understanding. And then we looked at how they describe civil society partners' role. Now, some of them have very sort of laudatory claims about the transformative role of civil society, but on the whole, we found that they specified most clearly the role of civil society partners in implementation. So in implementing the programs that the partnerships fund or facilitate. They also emphasized their role in brokering knowledge from the ground to the global level, and also conducting advocacy to mobilize resources for the funds. So typically, advocating for a fully replenished global fund or a fully replenished global financing facility we'll see on Monday. Whereas the role of civil society in terms of influencing actual decision-making or transforming change at all was not really that prominent in the discourse. We then looked at the level of representation that so-called civil society partners have in the governing bodies of the public-private partnerships. All of them have some sort of board or steering committee with clear structures for who's included or not. And there we see that civil society partners have a relatively low level of representation. So if we look at NGOs and affected communities, they have representation of about 10% of the seats of the governing bodies, which contrasts with the role of private sector representatives or partners who have almost a quarter of the seats. Of course, a formal representation is only one mechanism for influencing change, but we think it's still indicative of what importance civil society partners are actually afforded within these constellations. Now, we also then looked at who actually represents civil society in these public-private partnerships. Because the term is used widely, it's glossed without really being defined. And the NGOs and affected communities that are called on to represent civil society, who are they really? We see that the majority of them are actually international NGOs based in rich countries. Only a subset of them are patient or community representatives or developing country NGOs. And so the main representatives of civil society at the global level, where decisions about funding and strategy are made, are actually international NGOs that are based in rich countries. So really, these are organizations that, on the whole, represent hegemonic interests rather than presenting alternatives, and that have the greatest power within these NGOs. So what the key messages of our analysis really is here is that although most global public-private partnerships make quite laudatory statements about the importance of civil society in informing their strategies and decision-making, they don't really define what they mean by civil society, and they're not very clear about what their actual roles in these partnerships should be. We see that international NGOs are the main representatives, and furthermore, even though these are relatively powerful NGOs, they have a little formal power within the governance structures of the organizations. The civil society partners are valued for their role in project implementation, advocacy, and fundraising on behalf of the PPPs, but it's not quite clear what their role is in holding anyone to account here. So we think that we can't really take for granted statements like this one from Gavi, which is that civil society organizations provide input to ensure that programs and policies are robust, and that the Vaccine Alliance maintains a high level of transparency and accountability and responsiveness in its programming. Of course, our analysis really only scratches the surface of this. We haven't actually looked at the multiple ways in which civil society actors outside of these partnerships influence them, or the complex networks within which they work to put pressure. But we think it still highlights a problem in the way in which the term civil society engagement is used in global governance, and raises the question of whether the primary purpose of including civil society within these formal governance structures is to lend legitimacy to a governance model that really increases the power of private sector partners. We think that this analysis, I mean, we knew this really before doing it, but it reinforces our understanding that we need to understand more clearly and specifically what is happening within these engagement mechanisms. Now we have new ones that have been we did this analysis a year ago, but now we have active, like the UHC 2030 civil society engagement mechanism, the mechanism for the global financing facility, which we heard is meeting this weekend in Oslo. And it raises questions about what role these groups actually have and how they can navigate this extremely complex system to do anything other than legitimate power structures that are already there. So that's all I wanted to say now. I want to thank you all for listening and look forward to hearing the other contributions and the discussion later. Thank you.
Great. Next we have James Pfeiffer. Is it? Pfeiffer. Excellent. James Pfeiffer from the University of Washington and Health Alliance.
Can you hear me through this? Is it coming through? This headset's a little intimidating. I can't tell. Yeah, some people have trouble with my last name. No problem. My friend's 4-year-old calls me Change Diaper. So, I believe I am the first speaker here from an American institution, I think in the order. And there have been some Americans here who have fled to Canada. It's okay, but I feel obliged to bring you greetings from Mordor. So we'll talk about that as we go forward. So the title of this talk, I've sort of added a little bit here, Private Opulence and Public Squalor. That actually comes from John Kenneth Galbraith, who was describing America in the 1950s, and I'm going to talk about how I think that's an apt term to describe what's going on in the health sectors of many African countries. So talk a little bit about austerity. I just wanted to say that Dr. Rachel Chapman is a co-author on this work that we've been doing, and the paper that hopefully we'll produce out of this. She's here in the audience in the back and can help me answer some tough questions. So I'm on faculty at the University of Washington, but I'm also the director of an organization called Health Alliance International, or HAI, and we're kind of a funny hybrid. We're part of the University of Washington Department of Global Health, School of Public Health, but we act like an NGO when we do work in a number of countries around the world. So we have fairly large-scale projects now, implementation projects in Cote d'Ivoire, Mozambique, and East Timor. And I'd love to talk about East Timor maybe in the question and answer period if people have some, there's some good story to tell there. I'm going to be talking mostly about Mozambique, where HAI is what's called the PEPFAR implementing partner. We were the PEPFAR implementing partner for Central Mozambique for a number of years, and we are currently the PEPFAR implementing partner for most of northern Cote d'Ivoire. So we've done lots and lots of HIV work, so I'll be talking a little bit about that. Let's see here, how do I make that go? There we go. So we've already seen the definition of UH, universal health coverage, so I won't go into that. I wanted to just show this quote from WHO Universal Health Coverage document. Universal health coverage is firmly based on the WHO Constitution of 1948, declaring health a human right, but also that it is advancing or drawing on the agenda of the Alma Ata Declaration of 1978. And so I wanted to just reference that. I'll talk about why I think this is important for thinking about NGOs. You know, this is the 40th anniversary of Alma Ata. Hopefully all of us know that. I just show this picture. This is, non-Americans may not know, but this is Ted Kennedy, right? John F. Kennedy's brother, who was a very famous senator who worked very hard in the United States as a Democrat on health reform. He actually was part of the American delegation. I say that just to say that we had an American delegation that signed on to this very, very kind of revolutionary statement about health. Now, I don't think that would happen with our current administration, probably to state the obvious. So I just want to say the United States was on board with that. And just a reminder, I think everybody here understands this, but primary health care in Alma Ata were very much driven by voices from the global south and models from the global south. You know, they were really building on the idea of the barefoot doctor from China, on models of community health workers from Mozambique. The Mozambique delegation was actually a very important actor in Alma Ata. Models for basic health services coming from India. Very much in the spirit of decolonization, a period, following on the decolonization of much of Africa. The energy was coming from the global south to revolutionize how we think about universal health care. And I just want to say that I think this is important when we think about NGOs, is that I'm concerned, and I think it's a question for this group, whether the way that universal health coverage is now being sort of discussed feels a little bit like a co-opting, and perhaps, to maybe put a polemical phrase out there, kind of a recolonization of universal health coverage. And it's being dominated by voices of the very powerful folks from institutions in the West. And I think that's in real contrast to what happened at Alma Ata. And I think this is worth having some discussion. So I'm going to talk quickly about Mozambique. I was threatened if I go over 12 minutes, they won't pay for my hotel room. So I'm going to try to get through this. So Mozambique did begin building a public national health service with the intent of covering the entire population pretty much right after independence, after 1975. However, by the late 1980s, there was a terrible war that was perpetrated against Mozambique by apartheid South Africa. And Mozambique signed on to a structural adjustment program. We've heard a lot about that in 1987. By the late 1990s, as many of you know, structural adjustment was essentially rebranded as poverty reduction strategy papers. So I would say don't be fooled by the language change. Poverty reduction strategies are essentially doing the same thing, still constraining public spending. So Mozambique has really been under that kind of adjustment threat, really since the late 80s, and its spending on its public system has been constrained in that way. But we did see a huge, just a rapid history here, a huge increase in global health spending in Africa, but also especially in Mozambique in the 2000s with HIV funding, with PEPFAR, which I think everyone here understands what PEPFAR is, President's Emergency Program for AIDS Relief from the United States, which was really almost more than quintupling the funding from the US in global health aid. So a huge infusion. By 2008, there were 477 prime partners, NGOs, swirling around in the health sector in Mozambique, many of them feeding off the PEPFAR gravy train. And about $1.5 billion from 2010 to 2016 was spent in Mozambique as PEPFAR money. And it's estimated I believe by 2016, about $3 billion had been spent in Mozambique. By the last couple of years, the PEPFAR budget for Mozambique has been about $500 million a year, which is equal to the Ministry of Health budget. So you think, well, that's good. That's a lot of extra funding, but it came with massive data collection demands. If anyone's worked on a PEPFAR project, you know how insane the data demands are. But what we've seen over this period is very anemic health system growth. And so I'm going to be talking a little bit about where did all the money go and what does this dynamic tell us about financing or funding universal health coverage going forward. So this is just a graph of the percentage of PEPFAR funding by type of prime partner in 13 PEPFAR partner countries. And Mozambique is included in this group. But you can see here, fiscal year 2010, the green is nonprofit. This is 54% of this funding is going to basically American NGOs. I mean, this is a huge amount of funding. About 14% is going to for-profit organizations, right? And not sure who's included in that, ABT and others, Beltway Bandits, we call them. A mere 11% is going to the actual in-country government, which means that's how much money might be channeled into the actual health system itself. Academia, 20%, lots of universities getting money, including my own university, to study HIV treatment. If we look at Mozambique health sector financing, kind of a dizzying graph here, but just to make a point, this is going from 2009 to 2015. This purple here is what we call off-budget resources. So these are money coming into the health sector, you can all see that, which is mostly PEPFAR money, which is spent entirely outside the control of the Mozambican government for all intents and purposes. Here we have vertical projects, which includes other kinds of HIV funding, tuberculosis, malaria funding. Most of this, some of it grafted onto the National Health Service, but really outside the control of the ministry. This piece here is what's called Pro Saúde in Mozambique, which is really the common fund basket, or what's known as SWAP, sector-wide approach to planning, SWAP funding, which is where mostly Western European donors put money into a fund that's co-managed with the ministry, which is, I think, a good thing, but a smaller slice. And then this is the state budget, which the good news is it's increased, but it actually hasn't increased enough to keep up with population growth. So what you have here, if you look at especially 2013, only about 30, maybe 40% of the money coming into the health sector is actually under the control of the National Health Service, of the Ministry of Health. So we have quite an interesting dynamic here of who's in charge. You know, the Mozambicans in charge of their own health sector in their own country. And much of this driven by PEPFAR. So I want to tell just a brief ethnographic vignette, and this will not be a discussion with a taxi driver. We call that drive-by ethnography, by the way. I was in a meeting because HI was an implementing partner. We were receiving some of this money. I was at a meeting in Maputo with USAID and CDC folks who were from PEPFAR. We were in the big fancy JAT building. If you've been to Maputo, you feel like you're in the United States, a very slick, nice building. And we're sitting in the room with all the other heads of the implementing partners, and we're basically dividing up the country, right? Who's gonna get which provinces? What's the approach gonna be? How are we gonna do this? And there wasn't a single Mozambican in the room, and there wasn't a single person of African descent even in the room. And so this is my ethnographic depiction of what that meeting was. You may recognize this group of folks back in the 1880s at the Berlin Conference who divided up Africa, of course, that led to the Scramble for Africa without a single African in the room. And we, a number of us came out of that meeting saying, this feels kind of like the Scramble for Africa. All this money's flowing in, and all these folks from mostly United States, are dividing up the country in a way that is really going to be very important. Who gets AIDS treatment and who doesn't? And so here I am, right? Health Alliance International, FHI, the biggest recipient of PEPFAR money, hundreds of millions of dollars going to these outfits. There's a term we use in the United States for many of these called Beltway bandits. I don't know how many of you have heard the term Beltway bandits, but organizations within the Washington, D.C. Beltway that kind of work side by side with USAID and get no-bid contracts and that kind of thing. So, kind of logomania here with all the PEPFAR partners getting all this money. This is just a poster, just to, again, emphasize the kind of logo madness here of this is the NGO fair of all those working in health and HIV, and the USAID logo here, and you can just see all of these different partners that are fragmenting the health sector in Mozambique. So $500 million a year, equal to the Ministry of Health budget over the last 10 to 15 years. You would think, wow, well, we should see a really wonderful expansion of the National Health Service. All of this HIV work, this is the funny thing in Mozambique, these aren't groups by and large who are putting up their own clinics and treating their own patients. This is all stuff that's actually being grafted onto the National Health Service. About 90% of people in Mozambique get their health care from the public sector. So what they're doing is sort of piling on this work on the health system, but none of this money is actually going in to build the workforce, build additional health facilities, build new laboratories. It's all sort of training, but then when you actually go visit the health facilities, and Rachel and I spent a lot of time in health facilities in central Mozambique. We just completed a pilot intervention on what's called Option B+, test and treat for HIV positive pregnant women. And you go into some of the most high volume sites in Mozambique in terms of patient flow, but also high HIV prevalence along the Beira corridor. There's rain falling through the roof. There's no filing cabinets. There was only one MCH nurse in one of the places where we visited who was treating everybody coming in for whatever they had to be seen for, including antenatal care, but also postpartum care. And there was we did a time motion study, a 7-hour wait for a 5-minute visit for a pregnant woman testing positive for HIV. So we're thinking, okay, $50 million were spent in this province by ABT and FHI. Where in the world did that money go if it didn't go to this health facility? So very disturbing dynamic, very hard to track the funding because PEPFAR recipients and contractors are notoriously opaque in terms of their budgets. You cannot find out where the money goes. So I'm just going to end real quickly here. This is, I love this quote because it actually comes from the Congressional Budget Justification Supplement written by the PEPFAR folks. OGAC is the Office for the Global AIDS Coordinator based in the White House, interestingly enough. PEPFAR fiscal year 2016. It's making the case for why we need more PEPFAR funding. So just some interesting data here. Health facilities face frequent commodity stockouts and a general dearth of basic amenities. 55% lack electricity, 41% lack running water. These are essentially the same numbers that they were in the 1990s. With only 5 doctors and 24 nurses per 100,000 population and 429 social workers in the country, Mozambique faces some of the most critical human resource for health shortages in the world. Again, the needle hasn't moved at all in about 20 years. Mozambique is still rock bottom. And then this is the one that's the hilarity here, black humor. Information systems and monitoring and evaluation efforts are generally unable to provide timely and accurate health system data. About half the 500 million, as far as we can tell, goes into data collection for PEPFAR. But what the PEPFAR partners have done is they create entirely parallel data systems. And so they spend a huge amount of time. They take the time of public sector workers to provide the data. They take the data, they process it. It sits in data sets that are not actually accessible to the Ministry of Health, are not shared with the Ministry of Health. They go back to Washington, and then we're not sure what happens with the data at that point. But if anyone's worked here as a PEPFAR partner, you have armies of people that you have to employ just to collect the data. So you have this absurdity of, after almost 15 years of PEPFAR funding in Mozambique, none of this energy put into data collection has actually been focused on building an information system for the National Health Service where all this is happening. So sort of crazy ironies that are going on here. So I guess the point I'd want to leave with you today is, and I think many of you who've worked in Africa have seen this, is that we see the flooding of the health sector with NGOs, a preference for channeling funding to the NGOs, especially by American agencies, whether it's CDC or USAID. But much of it underlying this is the ongoing conditionalities, the ongoing austerity, and Mozambique is going through yet another round of austerity. Some health workers in some health centers haven't been paid in 3 or 4 months because of indebtedness, and the IMF, which has its omnipresence. And I'll just kind of leave you on this note. We just had lunch with the former Minister of Health, Ivo Garrido, who was the Minister of Health from 2005 into 2010 during the big HIV care scale-up. And he had read a piece that Rachel and I had written in The Lancet about, where's all this money going? Because it's not going to the health centers where we're doing this HIV work. And he said, what you guys described is exactly what I experienced. And I can tell you, I would go into my meetings with my own Minister of Health, and there would be sitting the IMF delegation, the Minister of Finance, and he would say, I need more health workers. We cannot possibly do this HIV work without hiring more health workers. And they basically said, no, here's the agreement we signed with the IMF. This is not a public document. You are not allowed to share this publicly, but this is the way it's going to be. So it's the Minister of Finance, I think as Robert Yates pointed out, basically saying no, over and over and over and over again as this health system sort of atrophies in spite of the hundreds of millions of dollars coming in donor funding. So a very, very frustrating position for ministers of health to be in. So just wanted to end real quickly. Do I actually have any minutes left? New research, I think what someone here at the conference in a coffee break mentioned the normalization of austerity. And I feel like we've almost talked about, we're past structural adjustment, but I think that's because it becomes so ingrained in how most African countries actually think about health financing. And I think we have whole generations of African economists trained in the United States who are now running ministries of health. And so you don't even need the IMF to be sort of the one with the stick. You've got ministers of health that do that work. So I would call for anthropologists to do more ethnography of the relationship of ministers of health to ministers of finance. See if we can go and sit in on those meetings, which of course we can't, but it would be a nice thing. I'll just end on a positive note. HI has been doing work in East Timor for about 15 years, and that is the opposite story. An incredible story of health coverage, of expansion of primary health care that has been extraordinarily successful. And one of the first things that the first Minister of Health of East Timor said was, we're going to build a health system, and NGOs, if you don't play by our rules, you have to leave. And a whole bunch of them left, and they have a fully free universal health coverage that has worked beautifully and marvelously. So I want to throw into question, are NGOs really part of our move toward universal health coverage? And I would say there's a role for NGOs, but we need to reduce the financing that flows to them now, and more support needs to go to actual health systems in the future. So I'll stop there. Thank you. Obrigado em português, from Mozambique.
Great, thank you very much. Great, thank you very much. So if some of you have not caught on, we have a reduced number of speakers and a reduced number of time, so they're matching up perfectly. So our next speaker is also from the Pacific Northwest of the USA, Nora Kenworthy from the University of Washington.
Like spot me. Okay. Hi, thanks. I'm so glad to be here and so thankful to the organizers. So for about the past 3 to 4 years, I've sort of radically shifted trajectories in my research to look at the rapid growth of crowdfunding as a means of health financing for individuals raising money for their medical costs in both the US and around the world. And this actually does come out of my previous research, which was about 10 years of very ethnographic research in Lesotho, looking at donor and recipient relationships and kind of the philanthrocapitalism that was shifting politics in the country. So I hope that you'll see some parallels here, and also with some of the other presentations in the panel. So for those who are not familiar with crowdfunding, crowdfunding for health specifically involves a financial appeal to for help with medical costs, which goes out to a large number of potential donors via internet and social media platforms. Some of you may be familiar with one of the most popular platforms for this, Gofundme, which has a massive sort of sector in medical and healthcare financing, particularly in the United States. So they host more than 250,000 medical campaigns a year, which raise more than $650 million for individual healthcare needs annually. And Gofundme is actually not alone in this new industry. We're actually seeing a number of other companies that are cropping up and creating similar platforms that are targeted to emerging and middle-income countries. So some of you may be familiar with Keto in India, with backabuddy and several other platforms in South Africa, also with Mchanga in Kenya. So all of these platforms can be described as sort of peer-based crowdfunding, in that they aim to connect individuals with their actual sort of intimate social networks who are expected to contribute to their healthcare costs. But in global health fields, we've also been seeing a parallel evolution of another kind of medical crowdfunding that I think we can think of as sort of philanthropic crowdfunding, which aims to connect individual donors in largely high-income countries with patients in need of funding for medical procedures in low-income countries. So in philanthropic crowdfunding, we see platforms like WOTC, which provides donors in rich countries with profiles of patients who are in need of care at partner medical institutions in the global south. This is a campaign for Edgar, who needs malnutrition treatment. And donors essentially get to choose on these platforms which individuals they will fund. Right. So I don't have enough time to really unpack the problematics of these very different types of platforms that are being used for crowdfunding today. So I'm going to refer you to other papers in which I have done some of that work. What I want to talk about today is actually how this new industry intersects with the themes of this conference. And I think there's 3 primary things to focus on. First, I want to show how crowdfunding thrives where gaps in health coverage are most acute. And in doing so, actually ends up fueling and perpetuating health inequities. Second, I want to discuss how it builds on and reinforces broader trends of marketization and corporatization in the UHC movements. And third, I want to explore how crowdfunding is both a political determinant of health and what I will later explain as a sort of technological determinant of health politics. So I'm assuming that there may be varying exposure to these kind of discussions around crowdfunding, depending on which countries you're coming from in the audience. At least in the United States, crowdfunding is completely inescapable on social media these days. I get appeals to contribute to campaigns on a weekly, if not daily basis. And it's also been in our sort of public conversations in the United States. And particularly in progressive circles, it's really been reflecting our discomfort with some of the implicit unfairnesses that are kind of built into these platforms. But I also want to highlight for you how a lot of this public conversation is sort of accepting a potential future reality in which crowdfunding would actually either complement or potentially even replace health insurance. And so a lot of this conversation happens with ambivalence and skepticism, but I actually want to take this notion seriously and grapple with it and think about how crowdfunding might be augmenting or potentially serving to replace health insurance in specific contexts. And so rather than see crowdfunding as this sort of like weird social media ephemera that's kind of reflecting our technological addictions and our anxieties about those tech addictions, I think we need to understand crowdfunding as a central figure and how technology may reconfigure health systems in the future, and what the implications of that refigurement might be for health equity. So in the United States and elsewhere, we are seeing people being driven to crowdfunding sites by gaps in the healthcare system. Our early research on this topic showed strong correlations between US states that had not accepted the Affordable Care Act's expansion of publicly funded Medicaid and a disproportionate usage of crowdfunding for medical and healthcare costs. Even with the myriad gaps and inadequacies of the healthcare system in the United States, however, crowdfunding is an extremely poor alternative to an already broken system. So 90% of the campaigns that we study have not reached their financial targets. We often find that people are only able to raise a few $1,000s in the United States. Now that seems like a lot of money, but it's not when you take into account that the average household costs for health insurance in the United States can be up to $10,000 a year. So this effect is not limited to the United States either. In Nepal, I've been looking at how the crowdfunding platform Watsi is actually kind of cultivating distrust of the public sector health providers because it only hosts fundraising for patient care at NGO-run facilities rather than public hospitals where patients have to pay quite a bit of money for acute care services. So in our research, we are thinking about crowdfunding as both feeding off of, but also fueling health inequities. And so health inequities are driving people to crowdfunding platforms in the first place, but once they are there, they're encountering logics and norms and processes that are embedded within these platforms that are perfectly poised to exacerbate health inequities. So at its core, crowdfunding is an infrastructure for amplifying people's choices in determining who gets access to care. And many, particularly those in the tech and the development fields, are talking about crowdfunding as democratizing aid. And instead, I would argue that it is radically marketizing aid and privatizing choices about who accesses care and amplifying social and health disparities. So to borrow a term from the tech industry, I think crowdfunding serves as an incubator for existing biases and prejudices and beliefs about deservingness that are embedded within society. So take, for example, the prospect of crowdfunding for stigmatized illnesses such as HIV or sexually transmitted infections, or even conditions that are linked to obesity, as in this campaign behind me. So it's not hard to imagine that even if patients with these conditions are brave enough to put their information online, they would likely face biases and perceptions that they are less deserving of donations. And these biases and perceptions then impede them from being able to access the care that they need. It's also very likely that race, gender, age, and other demographic characteristics heavily influence campaign success because of existing social biases that may actually vary from country to country. And so this is something that we are currently looking at in our research. We've also found that many crowdfunding platforms sort of inherently prioritize campaigns with discrete and solvable problems. And so in doing so, they make it harder for those with more chronic, complicated conditions to get the help that they need. Crowdfunding is this highly sort of downstream technology that works best to address severe, acute problems for which a kind of standalone expensive medical treatment is needed. So for example, Watsi, this global health crowdfunding platform, only puts up the campaigns of patients with treatable conditions who need a one-time medical intervention that they describe as having a high probability of success and that will cost less than $1,500 within the local currency. On Gofundme, we have found that those who have complex overlapping needs, like this family in a campaign that we studied, often appear and present as less deserving and having needs that exceed what a campaign can address. And so the more generalized one's distress, the more generalized one's poverty, the more complex one's needs, and the less likely you are to see success on crowdfunding platforms. So I want to take a moment to underscore how crowdfunding integrates and deploys many of the values that are sort of being leveraged in universal health coverage efforts, particularly the embrace of markets and technologies and privatization as a means of expanding coverage. So crowdfunding has a ton of kind of corporate ties that are really important to highlight. So global giving is often called the world's first crowdfunding platform. It was started in the early 2000s by two World Bank experts. And on its website, Global Giving heavily promotes its corporate partners, who include PepsiCo, Ambev, Pfizer, other corporations that have these really significant global health impacts. Caring Crowd promotes itself as the crowdfunding platform for global public health. They are sponsored entirely by Johnson & Johnson. Gofundme is a for-profit company, so it's not a nonprofit. It's considered one of Silicon Valley's most promising ventures in the past 5 years. It now controls 90 to 95% of the market share in the United States. It was recently described by TechCrunch as a cash cow, a vehicle for printing money. And WotC, which began as this nonprofit with a lot of support from venture capitalists, has actually recently used its experience in this global health crowdfunding sphere to launch a new corporation it calls Mezzo, which it describes as a modern technology platform for health insurance administration, in which it's marketing in developing countries as they're expanding UHC. So, all of these platforms share this reliance on and faith in the power of data, algorithms, online transparency, and equate sort of health access as being having access to technology. And what I want to underscore very briefly here is that technology is not neutral and is often highly designed to actually amplify inequities. It does that through algorithms that dictate that a trending campaign gets more and more attention on Twitter and on various social media feeds, whereas a campaign that's faltering actually becomes more and more invisible. And so I think that the technology as well can be seen as amplifying and sort of extending these inequities. And then finally, I want to also note that these technological platforms can be constructed as deeply disabling for certain populations. The campaign that we see on the right, for someone who's recently survived a stroke, it's difficult to tell here, but it seems possible that she is actually inhibited from adequately using this platform, in part because of her stroke. So this was the only thing that was on her campaign page, was this kind of one sentence that she wrote about having a stroke. I don't think I have time for this, but I just want to also note that there's a huge data transparency push that's part of these crowdfunding movements. WotC goes as far as to post records of every single patient that it's ever funded on a publicly accessible Google document. You can access it through the link. It's also highly possible and probable that Gofundme is selling data collected from its site to health insurers in the United States, who are then using that to determine where and how to price coverage. And so my point is that data transparency here doesn't necessarily translate into data fairness. So this brings me to a final point that I want to make about the political determinants of health. And so here we have a technology that continues to be pitched as democratizing, that is undermining investment in public health coverage and exacerbating and masking inequities. And so I also believe, though, that crowdfunding is what we might think of as a technological determinant of health politics, in that it is shifting the broader conversations and public values regarding health coverage in many countries. And in doing so, I think, is radically replacing the notion of a right to health with a faith in these hyper-individualized markets of need. So already in the United States, in our interviews with crowdfunders, we are seeing how they equate campaign success with worth and deservingness. So this really introduces this very false meritocracy that undermines struggles for a right to health. And crowdfunding is increasingly endorsed as a promising technology for healthcare financing. And so I think it's really urgent that we move quickly to show how this imagined future enabled by this technology imperils access to care for millions around the world. But I want to end with this like tiny sliver of kind of positivity. I'm going to try. So crowdfunding also opened doors to the possibility of imagining a different kind of future, I think. It reflects our collective anxieties. It underscores how deeply important healthcare access is to us around the world and how important it is to many of us who are voting and participating in political systems. I think the other thing that it does is it actually does amplify the extraordinary goodwill, the compassion and care, the charitable intentions of millions of people. And so I think there is a potential here to recognize our collective capacity for solidarity that's reflected through some of these sites, but also the possibility of harnessing these technical capacities towards building a radically more equitable health future. So thank you.
What can we say? So I just wanted to quickly, sorry, I'm sort of keeping not time.
Thank you.
So, because let me just give you 30 seconds. Do you have anything that you wanted to clarify, or should we just move on to questions? Nothing?
Questions.
Questions. Okay, so here's my rule when I chair. If you have a statement, just say the statement. If you have a question, say that you have a question and ask it, but don't try to confuse the two things because we're waiting for the question and there's actually no question. So who has either kind of a statement or a question? 1, 2, anyone on this side? 3, okay. So shall we start with you?
Statement first. What you just said, James, was completely deja vu because I think this was happening in Uttar Pradesh in 1994 with the USAID funding. And we all knew that the government health system was slowly being dismantled and decimated. And this entirely parallel system was coming in and it's continued to the day. The second one is actually a question also addressed to you. And that is, in India, while at the federal level, we have somewhat, capacities for implementation, monitoring, management, etc. The minute we go into the subnational level, capacities decline sharply. And so at the subnational level, the provincial governments tend to look at development partners as their solution. And so in the name of technical assistance, all of these various actors are then actually seated within the Ministry of Health. So how do we address this kind of dichotomy? Perhaps in the African states, that's taken as a given that there is lack of capacity. How do you address this dichotomy and ensure autonomy and capacity building?
So let's pack the questions together. So we'll take, so there was 10 and then there was, okay.
Right. Is it necessarily a good thing when a national government says NGOs have to play by its rules or leave? I take your point about the case example, but there are other situations in which surely there's an argument for funding NGOs directly rather than national governments. I mean, India and Turkey, among other countries, have also told NGOs to play by their rules or leave.
Thanks. Question for Nora, if I may. My daughter was going to give to a GoFund thing about something completely different, but then decided that she wasn't going to because she had heard that GoFundMe explicitly won't fund terminations of pregnancies. Is that correct? Have you heard that you're not allowed to fund abortions through GoFundMe?
Yeah, this is a statement. It's also kind of a deja vu. In 1990, we published in UNDP a book called Rethink Technical Assistance Capacity Development for Africa, which was very critical analysis of technical assistance. And actually, since I was one of the authors of this, I was told that I had to burn every single copy of the book, since it was not very much in the interest of the organization that published it. But what I want to, the statement is that we've known this perverse effect of donor money on capacity in Africa for many, many years, for decades. Why doesn't it change? It's because of power, right? So this is what this conference is about. And it's the power, the asymmetry of power between the donor and the recipient is exactly what we need to investigate. And it's the norm of charity model of aid as motivated by charity that reinforces this, that says that the donor has all the power because it is not asking for any kind of reciprocity, that it's a pure gift. And this is sort of anthropological theory of the gift that would explain why the power asymmetry is reinforced in a charitable model of aid.
Okay, who wants to take the question?
Okay, is this on? Yeah. Great questions. I guess I would frame something I didn't mention as strongly as I'd kind of hoped to is, we haven't used the word neo-colonial in this room very much, but your last comment kind of reminded me of that. I think there is a premise in the culture of the NGO and the foreign aid industry coming out of the West that reminds me of what the apartheid regime used to say and remind me what colonial powers would say, is that Africans can't govern themselves yet. They need us. And you hear that all the time. I was just in a meeting in Maputo in September, and we had some meetings with some of the PEPFAR partners and with the ministry. The ministry is furious at the PEPFAR partners at the moment. I don't think I'm breaking any confidence in saying that. The 300 health workers from the National Health System left in 2017 to go work for PEPFAR partners. They're being decimated. The National Health Services, in many ways, it's kind of a strong word to say, but it's kind of being eviscerated now. And it's hard not to see this in many ways as a neo-colonial enterprise. And of course, Mozambicans will use that word quite frequently. And I think that is part of the historical framework that we have to not be afraid to kind of say that there's the power dynamics, which also have racial dynamics mixed in with them, are very concerning. And sort of this sense that I hear it over and over again in Maputo that the Ministry of Health really can't do this. They're incompetent, they're corrupt, they're not able to do this. Our experience at HAI is they're the only people who do this very well, is the National Health Service, in fact. So, but there is that conflict. So that speaks, I think, to the autonomy issue, is that when they are not able to have a robust national budget for health services, they do end up having to rely on outside help. And I just think that's part of the dynamic, is they're just not getting, they don't have the health workforce that they need. And so they have to rely on this outside. They're really stuck in a real bind because of these austerity measures. I mean, I think that's the broader picture. Just another little ethnographic vignette. Working with the provincial director of Sofala province, who we're outlining an annual plan that HEI tries to work very closely with the public sectors in the countries where we work. Everything we do tries to be aligned with their planning. And the provincial director said, we really appreciate what HEI is doing, but you know what we really need here? We really need accountants. We need some IT people. Our computers are filled with viruses. We need all this stuff. And yet our donors don't allow us to give them what they really need to build their own capacity, right? There's just this basic mismatch. They need all this help with their health information systems. What do? We go create a parallel one, right? So I don't know if that fully answers your question. I don't know exactly what the answer is, other than us speaking out in forums like this and people who have seen these dynamics, deja vu. And whenever I give a talk like this, everyone says, oh, I've heard this. This is exactly what I've seen. Everybody knows this is what's going on. As you said, it's power that prevents us from taking it on. Just make sure I've answered.
Did you answer the NGO?
Right, the NGO issue. I think there's a bigger issue of, is there a role for NGOs? And I would say that we can make a case for why there's, civil society is a very important role for NGOs to keep governments accountable, I would argue. I mean, that's a much broader discussion in which you would want some independence and autonomy. But I think when you're talking about NGOs providing support for provision of actual services, the idea that they're substituting national public sectors or they're diverting money from a public sector, that's where I think the biggest problem is. Not that there might not be a role for NGOs in some way. I don't know if that answers the question fully, but that that the rechanneling of money away from NGOs into national health services is urgent.
Okay, so you okay? Or is there anything that you want to...
I can respond quickly to the last question.
Do you have a mic? You don't have a mic.
Thank you. So really quickly about the question with GoFundMe and abortion, in the past they have canceled campaigns that were fundraising for abortion. I've been able to find campaigns that are fundraising for abortion, so I'm not clear on how closely they monitor. But I think the broader question is that GoFundMe and these other sites have been thrust into this sort of like role as public moderators of what is and is not acceptable to crowdfund, and what is and is not fraud, for example. And then I think the larger concern that we should have specifically with GoFundMe as an ethical concern is that they are making money off of every single one of these campaigns. So 5 to 10% of what the campaign raises actually goes as profit to GoFundMe.
Okay, so we had someone in the back. So there's one question there, and 1, 2. So there's three questions and not enough time. So we need to get the person in the back. The mic. Do you want? So she's waiting for a mic, and then that's 2, and that's 3.
Thanks, it's Sanya from Third World Network. I was interested to hear about the issue of algorithms in crowdfunding because the e-commerce proposals for 164 countries at the WTO would restrict the ability of governments to check algorithms or source code to see, for example, if they ban abortions or put them at the bottom of the list. And it's been in some free trade agreements that are being negotiated as well. And your question about whether GoFundMe could sell data to health insurers and so on, some governments are concerned about that, so they require things like health data to be stored locally so local privacy rules apply. But again, there are proposals in the WTO and in free trade agreements to prevent that so that GoFundMe can send the information to any country they want in the world where it can be sold to whoever they want and used against patients however they want.
Hi, my name is Aaron Yarmashuk. I'm from the University of Toronto, and this is a statement and some shameless self-promotion, and I apologize for that because I usually always ask questions. But the comment about models that work for capacity building, you spoke about NGOs. I worked for an NGO for 7 years, 4 years in Malawi. I cycled across to Mozambique, 7-day trip in 1995. I'll make this very quick, 1995. I appreciate the challenges in Mozambique. I then worked for the University of Toronto, managing partnerships between the University of Toronto and universities in sub-Saharan Africa. And while I the university may have desired that I worked on research partnerships, I actually worked on capacity building partnerships and then did my PhD. And there's some really great models of university to university partnerships out there. I became familiar with and helped U of T join one in Kenya, Moore University, the AMPATH Consortium Partnership. You have what the Swedish universities have been doing in Tanzania, and then you had Swedish SIDA allow Mulimbili University to design their own project and to have bidders from Sweden compete for it. And then you had NIH in the US give their, I think it's an $80 million grant to more university in Kenya that benefited from the capacity building of Indiana University. So there are some very good models out there, and people just need to look at them. And if you Google my paper, you will see the higher value partnerships between universities and what makes them higher value. My apologies for this shameless self-promotion.
Hello, I'm Tammy Boyce, and I'm working with the WHO office in Venice, which is the Office for Health and Investment. And one statement and one question for Katerini, so no one's talked to you yet, but I will. But I just wanted to say that my experience, I'm so glad that James was here talking, because yes, it's also, don't just say it's happening in Africa, it's happening everywhere. Certainly in the offices that we're dealing with in Europe, the examples that you're talking about are, I had a meeting with this and was talking to Desmond about this on Thursday when we met, and just said, how do we get the Norwegian fund to stop funding training in some of these countries? Because you can only train them. If you train them for 20 years, surely we can have some outcomes besides 8 people trained in this province, 12 people trained. It is appalling, and it's happening everywhere. So thank you for raising it. But for Katerini, I just wanted to know, okay, I loved hearing civil society is not a panacea, because I say it all the time as well. So we're echoing each other. But where does it work anywhere? It's always easy as academics to point out where it's perhaps not as it should be, or we don't really understand what's going on. But have you found anywhere where you think, yeah, okay, this is actually working quite well?
Okay. Thank you very much for the question. I don't know the answer. That's why I was hoping to continue doing research, but I'm sure there are other people in the audience who can tell us. But I don't think that incorporating civil society organizations within the charity model is necessarily the answer, which I think is what these new formalized mechanisms of civil society engagement do. Like, I just question the extent to which whether that actually can be a way forward, and whether it just sort of diverts the attention from actually challenging the power dynamics of that model. And then I think that there's an issue about conflating civil society with NGOs and asking, I think people talked about this yesterday, whether what we need is social movements rather than NGOs to challenge these politics. But I do welcome the solution from anyone in the audience who knows.
My apologies to everyone in the audience. We just don't have time. We have to break for lunch. So, and also my apologies, speakers. I'm sure you would have loved to have another half an hour to give your talks. So can we give them a big round of applause for their...
Thanks to you all.